Well, welcome. This is Sean Holzman, Education Director and General Training Guy, and we are going to do this module called Airway Control Overview. Basically, we're going to be putting the Bougie introducers onto all the ambulances for assistance with intubations, and if you have not used the Bougies before, there's a little bit of a training that's involved with it, so we're going to overview some of the basic airway stuff, and included in that will be the Bougie and how to utilize that to assist with intubations. This is a good module even for basic providers if you're not doing advanced airways, because there's a good deal of anatomy overview and reviewing here as well. So hang on, there is a test at the end of this which you'll have to complete in the ePro program. There's also a hands-on portion which will be facilitated by myself or by one of the supervisors who have been credentialed, and hopefully within a week or two we'll have all the ambulances stocked with the Bougies, and we'll be using them. So here we go. The objectives for this lesson: you should be able to identify anatomical airway features. We're going to talk about several of those. Identify various airway adjuncts and equipment. You probably know all the stuff that we carry, and we'll be going over the Bougie today, so that'll be additional equipment to learn and be able to use. Explain and perform BLS procedures for airway control, so that's going to be your suctioning and all that stuff they do as basic EMT. Same thing for securing advanced airways. We're going to demonstrate proficiency in intubation using the Bougie introducer, and that again is something that you'll do hands-on with either myself or one of the supervisors. Identify possible airway complications. We'll talk a little bit about what can happen to the airways and things that would make it difficult for you. And as a little addition to this, we're also going to talk about the AutoVent 3000. Some of you have not had the pleasure of using the vent on a call before, so that will be part of the training as well, just to get everybody up to speed on what the vent is and how it is used. So airway anatomy. Remember, we've got a lot of things in the airway there. This is a cutaway view, clearly, and in order of appearance, as you enter the mouth and go into the airway, we're going to see these things: the teeth, the tongue, your uvula, the vallecula. Remember, that's a little spot that's just above the epiglottis there. You can engage with your MAC blades when you're using a MAC for intubating. Your oropharynx in the back, larynx, and then your esophagus is down here as well. So these are some of the things that we'll be seeing as we go through the airway and looking for the vocal cords during an attempted intubation. So this is a view. I just skipped. This view is a patient who is supine, and this is what we'll see. If you are at the head and you're getting prepared to intubate, or you're thinking about intubating, this is the view you'll see if they just open their mouth, and when you start to put your blade into there with their laryngoscope, you'll see some different structures as well. We're going to come back to this view in a little while because it's important, but as you can see, teeth, uvula, the tonsils are back here. There's your epiglottis. So we'll be looking for these landmarks as we come through. Now, something to think about. Per New York State BLS Protocol, all right, we're going to be doing ventilation on any patient who's breathing at less than 10 per minute, or not breathing at all, obviously. Cardiac arrests, respiratory arrests, we'll be doing that. One of the things to keep in mind is, why are we controlling the airway? Well, a couple things. We're trying to ensure ventilation. We're trying to ensure oxygenation, and those two things are different. And if you have a chance to review the capnography module that we have online, it talks a little bit about the difference between those two things, but they are different. Protect from foreign body substance obstruction, so if you have something in the airway that can get in the way, that is bad, and by controlling the airway, we're stopping that from happening. And also, again, protect against aspiration. Keep in mind, especially for your cardiac arrests, you get somebody who aspirates some stomach contents, if there's vomit in the mouth, and that's very heavy acid. It's going to damage lung tissue, and it's also going to cause people to have pneumonias at least. So we do not want to get stomach contents down into the lungs, and if that happens, we're in bad shape, or the patient's in bad shape. Please remember to use the adjuncts. It's one of the most forgotten things that paramedics have going on because they're concerned about getting the tube and they don't always use the adjuncts. So OPA, NPAs, remember to put those in there. Basic people, you can save your paramedics by making sure these go in. That's your job. So help out there and get the basic adjuncts out. If you're bagging somebody ventilating, see if you can get one of these in there. Just recall the proper ventilation rate according to the AHA and all the classes you're taking. Non-intubated patients are going to get one breath every 5 to 6 seconds. or 4 to 5 seconds for pediatric patients. And then patients who have a tube in are going to get a breath every 6 to 8 seconds. Don't hyperventilate. And again, if you go review the capnography protocol or the capnography presentation that we have online, we talk a little bit about hyperventilation and some of the bad things that can happen because of that. So, OPA versus NPA. Remember, we're going to use the NPA whenever there is a gag reflex to the oral pharyngeal airway, but the patient's still unconscious. So, this is going in the nose. They used to call it the nasal trumpet when I was young. Remember, you got to lube that up before you put that in there. This is the proper measurement technique where you're looking from the edge of the nose to the earlobe, and that will tell you what size to put in the patient. Be advised, if you have a patient who's got facial trauma, possible skull fracture, good whack to the head, there's bleeding from the nose or mouth or anything that would indicate that there's a possible skull fracture, especially a basilar skull fracture, don't put anything in their nose. This is a cool view of a nasopharyngeal airway that went into the brain through a crack in the skull, and then there's multiple online pictures you can find of this NG tubes going and wrapping around into the skull because they were fed in during a basilar skull fracture. This can also happen with a nasal intubation attempt. So facial trauma, serious head trauma, don't put anything in the nose. It's not good for your patient to have their brain pierced. Clearing the airway. As a basic provider, or hopefully as a ALS provider as well, we're going to do two options. We're going to turn the patient to their side and let vomit and secretions drain out. We're going to use suction to remove the vomit and secretions from that airway. That is our job, keeping that open. You've all had that situation where you have copious amounts of emesis and basically you just leave the tube in there with the suction running. Whatever you need to do to get that cleared out, you don't want to have the patient aspirating stomach contents. And in a lot of cases, if you're going to put a advanced airway in that requires a laryngoscopy, you're going to need some of that secretion moved out of the way so you can visualize what you need to see. ALS, we have a couple extra options here. We have the McGill forceps. This is our buddy Ivan McGill who invented them. And these are, as you know, designed to go into the deep parts of the pharynx there and pull chunks of whatever out of the way if you get big pieces of things in the throat. So this can help you remove foreign body obstructions. And then we're going to use deep tracheal suctioning too, which is of course a paramedic skill and something we'll do once a patient is intubated if need be. So we got a couple of options to clear the airway, and hopefully we're doing that with regularity. There's the supraglottic devices, and those supraglottic devices are blind insertion airway devices. There's a lot of different ones out there. Right now we are carrying the EOA, obviously. In the future, we may see other devices come in here, but there's many. There's the combi tube, the LMA, the salt airway, the king tube. These are all airway devices that are designed to help you ventilate a patient. They're all useful in their own way. The problem is that they don't do a couple of things. All right, none of us can get direct access to the trachea and lungs through these things. So if you're trying to get a deep suctioning going on, that's going to be an issue. If for some reason you were inclined to put any medications down the tube, which we're getting away from nowadays, that would not be possible through most of these airways. And the other thing is that most of them don't completely protect a trachea from aspiration. The best ones for that are probably going to be the king tube and even the EOA that blocks off parts of the esophagus, but still not airtight, and it's not going to keep you from getting a lot of stuff into the airway in the event that you have a vomit happening or some kind of emesis. So these are good secondary devices, and they're good to use if you can't get a tube, but they're not something that we want to be jumping to automatically. There definitely should be an intubation attempt before you're using these secondary devices. Or if there's some reason why intubation is going to be impossible, that's when we would use the secondary device. So, I'm not going to try to pronounce that name. I think it's, okay, Achabahian. We'll try that. Dr. Arthur Achabahian, who is an author and an anesthesiologist. He says, intubation of trachea using a cuff tube is the gold standard to ensure airway patency and protection. Endotracheal intubation allows for the provision of positive pressure ventilation to patients receiving general anesthesia or experiencing respiratory failure. So, gold standard. What gold standard means in science and medicine, folks, is that it is the way to go if you can. It is the optimum way to do something. So if we're talking about intubation being the gold standard, we should be looking to do that. You take your AHA classes nowadays, they are downplaying the airway, the advanced airway. They're saying that if you have a patent BLS airway and it's working, that you don't have to worry about the advanced airway. I am not a physician. I don't make the protocols for those classes. I do not agree with that. My contention is that if you have the skill and ability to intubate a patient, which is the gold standard of protecting the airway, you should be doing that. And if you don't do that, your BLS airway is great until it's not. Once the patient vomits, once something else happens, there's swelling from inhalation burns or something like that, once you lose that BLS airway, it's going to be very difficult to get it back. So we should be doing intratracheal intubation. We should be using the equipment and the skill we have to do this. And I would highly recommend that if you have patients who require advanced airway control, that you are making intubation attempts as your first pathway to try to make that happen. ET tubes completely secure the airway from aspiration to foreign bodies, so you're not going to get anything in the lungs if you've got a tube. Provides direct access to trachea and lungs, so if you have to do suctioning, the patients with the CHF, those situations we're going to have the ability to do that. And it's going to ensure accurate tidal volumes as well. So that air is going directly into the lungs. If you have a vent that's coming on there, that's the way we're going to be able to go, is get the air right into the lungs through that tube in an exact tidal volume that we have on a setting there. So we should be looking to do this, and I'm hoping that more people are going to try intubating when the situation arises. The problem with intubation is this, and this is a view we had earlier today. In a supine patient, we're going to see these things, and remember, we have to get the tube from here by the lips all the way down here into the back of the throat. That's a pretty wicked curve there. So this is the issue. This is the main problem with intubating patients, is that there's this curve here. We have to negotiate this whole airway situation and get around the tongue and everything else here so we can actually visualize the cords, which are anterior to the esophagus. So that's the problem, and that's why intubation is a skill that people sometimes struggle with, because it's going around a pretty wicked curve there. Flip top head would be great. If we could have a flip top head and drop tubes in that way, wouldn't that be awesome? Unless your patient has a severely traumatic injury, not going to have a flip top head for you. So it's not going to be quite that easy, but wouldn't it be nice? 3 things to remember when we're doing intubation. And this is review, but it's important review. And a lot of us forget some of these things as we go through and get older and spend more time in the field. We forget some of these things. So I call it the 3 Ps. We're going to do prep, position, and progress. If you watch people in the OR intubating, doctors who do this for a living, anesthesiologists, they do this in a planned and orderly fashion. They are relaxed, but they're also doing it in a quick fashion because it is time sensitive. Once you've paralyzed a patient in an OR setting, that patient needs an airway immediately. So we have prepping, positioning, and progression. Prep. Here's the deal. If you're going to be tubing a patient, chances are it's going to be a critical high-stress call. Critical calls cause stress. Your stress kicks in. It really decreases your fine motor skills. It can inhibit your critical thinking. And, if you have yourself prepped beforehand, it's going to decrease a little bit of that stress. It's going to keep you a little bit more focused. You're not going to be searching for things, dropping things, trying to find pieces of equipment that you need. So once you've decided to intubate, you want to do these things. First of all, you want to ensure that proper ventilation is occurring with your BLS adjunct. Ideally, you're going to have fire or your partner there who's going to be helping you do these things. And remember, as the medic in charge of the call, it's going to be your job to make sure that that's happening properly as well. So you should be scoping them out, making sure that they're not hyperventilating patients and that they're doing things properly. You're getting good seal, you're getting good chest rise. The other thing you want to do is lay out your stuff. Don't dilly-dally, but at the same time, you want to make sure these things are there in front of you. They're ready to go. So you have your laryngoscope out. You have 2 different blades. Generally, you want to get your favorite blade and then bring a second one, and I'll talk about that in a second. 2 tubes. Generally the size you're going to use, and then bring one size smaller just in case you get in there and things are a little more cramped than you thought they were going to be. You can use a smaller tube that's already ready. You want your 10cc syringe ready to go. You don't want to be looking for that at the last minute. Your tube tamer, and have your Bougie introducer out. So we'll go over that in a couple minutes here, but get that ready. Have it good to go. That preparation is going to help you decrease your stress, and you've heard of muscle memory. If you play a musical instrument, muscle memory is when you do the same thing over and over again, your muscles just naturally go to those places. If you practice this, if you have a setup that you do before you tube, then that's always going to be the same for you, and you're going to be able to fall back when you're nervous or stressed or having a difficult airway intubation. You can go back and have your equipment right there, and it's right where you need it, so you can decrease some of that stress. Positioning. This is where many of us fail. All right, sniffing position you've all heard about, but very few of us actually do sniffing position properly. If you go into the OR and watch them, generally you're going to see this situation where the patient's going to be on the bed and they're going to have their head, not their shoulders, their head elevated onto a pad. This elevation of the head and then the tipping forward of the jaw, or tipping back of the jaw into that extension position, is going to be what actual sniffing position is. And this is going to help you get the best visualization of the chords possible. Not saying you're going to absolutely be able to see the chords perfectly, but this is going to be the best position to get them in. So when you go into the house, if you can get a pillow while they're on the floor, or if you can get towels or a blanket, whatever you got, put it under the head, and then you want to hyperextend. Now, obviously, this is going to be in a medical situation where you're not suspecting trauma to the spine. There's a 3-axis theory that we want to talk about here, and this is what they do in their anesthesiology training. There's 3 axes, and basically true sniffing position aligns these axes so that you can get a best visualization here. So you have the laryngeal axis, which runs right here from like the Adam's apple up to the top of the head there. You've got your pharyngeal axis, which runs parallel to parts of your pharynx there, and you have your oral axis, which just runs from the mouth to the back of the throat. So when the patient is sitting in neutral position, you can see all 3 of these axes are very different from each other. But as we elevate the head and then tip the head back, we're getting the best, closest alignment of these 3 axes. So how do we do this? Head elevated on padding, neck extended, chin lifted. And here is a view from a CT scan of what this looks like when the patient is in various positions. Remember, this is medical. This is not trauma. Trauma patients are going to have collars on. We're going to be concerned about the spine and the cervical spine, and we're not going to be yanking the head around, but this is for a medical situation where we're not expecting trauma. Progress. They call it progressive laryngoscopy because it's just that. It's progressive. So you want to insert the tip of the laryngoscope blade into the right side of the mouth, and you want to do this slowly. The tip of the blade goes in, and you're slowly progressing. You're going little by little down into the deeper parts of the throat. While you're doing that, you're pushing the tongue up and over to the left, out of your way, so you can visualize the chords. A lot of people do this cranking thing. All right, and we don't want this cranking fulcrum type situation. So this is what up means. Up means away from you in the direction of the axis of the handle of the laryngoscope blade. If you find yourself cranking back on this, if you find yourself tipping the laryngoscope back towards the teeth and bending your wrist, you're blocking your view. This corner of the laryngoscope blade will drop in front of you when you crank this back, and you also run the risk of damaging the teeth and other structures on the face here. So up and away is what we're looking to do. As you progress, you want to slowly visualize landmarks. You know what they look like. We all know where the landmarks are and where they are on the throat. When you start to see them, then you know what you're looking for. So uvula, the epiglottis is right here, and we know directly under the epiglottis is where we're going to find the vocal cords. So in a minute with the Bougie, we'll talk about this, but even if you can't see the vocal cords, you know where they are. They're right under the epiglottis. And then obviously this is your vocal cord with your posterior cartilages and everything. So we're looking for these various structures as we go through. Here's another progression. Uvula, then we have your epiglottis, then we can see the posterior cartilages there, and there's the interarytenoid notch, and then you have right posterior cartilage over here on this one, so here's your cords. So again, you're just slowly progressing into the throat with the blade, slowly. If you just jam your big Miller 50 in there and you go as deep as you can, you're going to be looking at the esophagus. Then you have to back out and try to find all these structures. So it's easier to start in slowly and do the progressive laryngoscopy. Take a deep breath, get in there, and check things out. This slide's a little messy on this one, so we'll do a couple things here. When you're looking for this, remember the larynx looks like the horrible alien creature. So here's your epiglottis. Remember, it's triangular. Your vocal cords are very, very obvious here. These are your posterior cartilages, the notch. It's a triangular shape there. Sorry. So if you see this, there's no question where you're at. The problem people sometimes have is they don't see cords, or it's dark, or they can't get a good view, and they see this little hole here. So remember, the larynx looks like a horrible alien creature, and then the esophagus is a boring hole. All right, there's no exterior features. It's round or oval. It's dark. There's nothing there. In this picture, you can actually see the just the very bottom of the glottic opening here, with the posterior cartilages there just above the esophagus. So don't get them confused. You should be able to visualize your tube going in, and if you can't, that's what the bougie is going to be for. But don't put anything in the boring hole. Talking about difficult airways, and this is part of the reason why we're going to be putting the bougies onto the vehicles. Difficult airway, there's some factors that will increase the difficulty of your intubation. Obesity. If you get your large, heavy people, a lot of times there's a lot of tissues there. They don't open their airways very well. Difficult to see. Vomit, blood, other secretions, especially in a trauma situation, you may have a difficult time seeing because you have stuff in the way. Any anatomical anomalies of the airway, and as medical providers, we shouldn't be surprised by these things, but we always are, and there could be stuff in there. Remember, surgical scars from tonsillectomies or infections. There could be tumors in the airway. All those things, we got to be able to identify landmarks, even if they don't look exactly like this textbook shows them. So there could be things in there that are issues. Cervical mobilization, or if they have some kind of problem physiologically that decreases their mobility of the neck, is going to definitely be an issue for us. Oral or laryngeal edema, so you get your anaphylaxis patients or people who have come out of the house fire with some hot air burns. You're going to start getting some swelling in the airway there, and that's going to make the landmarks look different, make them bigger, and eventually can actually strangle them out with complete swelling closed of the airway. History of obstructive apnea syndrome. So if you get people who have sleep apnea from the snoring, that is going to be an indication that they're probably not going to be as easy of an airway as you want it to be. And then, of course, the Mallampati score, which we've got pictured down here. I've heard people actually say if you get somebody with a class 4, don't even bother trying to intubate. I would say use your best judgment on these calls. If you can get an intubation there, or especially using an adjunct like the bougie, that's great, but expect that you're going to have a hard time if you've got a high Mallampati score, and just assume that's going to be a difficult airway for us. So basically anything that's going to block us from seeing, anything that's going to keep us from getting a good view of the cords is going to be considered a difficult airway. Which brings us to the bougie introducer, or the gum elastic bougie. You've heard a lot about this. People have been talking about this for a while. It's a semi-rigid introducer. And what an introducer is something you insert into the trachea by itself first, and then you feed a ET tube over this. All right, so what the bougies are, they look like this. They're fairly long. They've got an upturned end. And basically, when you can't see the cords, or when you can barely see the cords, this is placed in, and then you put that into the trachea, and then your ET tube goes right over top of it. So this is kind of like a guide. You're threading the tube into the trachea. And we'll talk about this procedure here. Right. Let's say you're looking. So there's still a direct laryngoscopy involved. You've still got your blade out. You're still looking to see the cords. All right. But let's say this is the best view you can get. All right. You're in there. You're looking, and all you can do is see this tiny little portion of the glottic opening there. All right. That's the best view you can get. If you try sticking an ET tube in this, as soon as that tube gets here, it's going to block your view of everything. It's going to be much wider than this area as you put it through, and you may or may not hit the cords. You're not going to be able to probably see this go into the cords if this is the best view you can get. So the bougie, on the other hand, is thin enough that you can place it into this opening right here. It also has the upturned end, so it can go up under the blade of the laryngoscope and go into the trachea and get in that way. So obviously watch out for the boring hole. And then once you get the bougie into the trachea, we can use that to thread the tube in. Here's another poorly visualized airway. If this is the best view you can get, we talked about this earlier, this knowledge of the anatomical structures. Here's your uvula, here's your epiglottis. Where are the cords? They're up and behind this. You know that. unless the person is an alien, that's where their cords are going to be. So even if you can't visualize any part of the airway here, you can still see where the cords should be. They should be up and under the epiglottis. So you'd use the curved end of your bougie, and you would do a nearly blind insertion. So your blade would be in here, but you would just touch this to the upper aspect of the epiglottis here and just ride right along the top of this with that curved end pointing up, staying midline, and at some point you will hit the vocal cords and you'll go right between. That's the whole purpose of the bougie. Right? So you're going to maintain midline alignment, and you're going to keep this upturned part of the bougie facing up and under the epiglottis here. Once you get the bougie in the trachea, you're going to hold it manually, and you're going to feed the ET tube over it. So it's threaded over top of it. So basically it's a placeholder. The bougie is in the trachea, the tube goes over the bougie and then goes into the trachea as well. How are you going to know if you're in the trachea? Well, for one, you probably won't be able to progress that bougie very far past 26 centimeters. There are markings on it because it's going to stop. It's either going to hit the carina or it's going to lodge in one of the mainstem bronchi. So you're not going to be able to get it very deep. If you keep pushing the bougie and it keeps going in, you're probably in the esophagus. The other thing is occasionally, sometimes you can feel the cartilage rings as the bougie kind of clicks over them as you put it into the airway. This is not always the case, but sometimes you can feel it. So you can do that as well. And the other thing is, if you actually were able to visualize the bougie going into that little part of the glottic opening on the bottom there, you'd be able to know it was in. You can do this two ways. You can actually put the bougie in first and then feed the tube over, or you can preload the bougie into the ET tube. And this is really a style preference, whatever you prefer to do. And either way, this is going to work. But in one way, you're putting this in and then you're feeding the tube over it. And the second way, you're actually doing it all at once. Once your ET tube is inserted the proper depth, you're going to do a little bit of a counterclockwise turn. The end of the ET tube has a bevel, and that can get snagged on the cords. So once this gets down to where the vocal cords are, you're going to do a counterclockwise turn just to slowly get this to push through the cords so you're not getting snagged and damaging the cords. And then you're going to insert this to the proper depth, and you're going to continue the intubation as you normally would. You're going to pull the bougie out while holding the tube in place. I heard someone refer to this as the lawnmower. You don't want to grab that bougie and yank it out like a ripcord. That's going to possibly pull your tube. So you want to slowly hold your tube in place and slowly pull out the bougie there. You're going to fill your cuff, check your lung sounds, apply capnography, and do everything else. So hopefully this has helped you get in. All right, some important points to remember while you're doing this procedure, and you're going to have an opportunity to do this hands-on with one of us. Cartilage rings can be felt by gently moving the bougie forward when it's been inserted, and this can confirm placement, but not always. Just because you don't feel the cartilage rings does not mean you're not in the trachea. So it's a good indicator that you're in, but if you don't feel it, it doesn't mean that you're wrong. There's markings on the bougie to let us know how far it is, just the same as the tube. So you want to use them so that you don't insert the bougie too deeply. And it also lets you know where you are when you're trying to put the tube in. So if you're at 25 centimeters, say, and you put your tube in, and by the time you get your tube on, loaded up, you're at 15, you may have pulled that bougie out. So again, you may meet some resistance at some point if you're in the trachea, generally the carina or mainstem bronchi. When you've threaded the ET tube over the bougie and you get to the vocal cords, remember that little counterclockwise turn. So you're going to turn your tube counterclockwise. This is going to help prevent or dislodge any snagging that's on there. Keep in mind the bougie is semi-rigid. It's pretty soft, but the tissues of your mouth and the airway are sensitive. So just like anything else, we don't want to be jamming anything blindly into the airway. You can cause bleeding and damage to the airway, and that's just going to be more difficult for you to tube. And if you can't get it, it's going to be more difficult for the hospital to tube when you get there. Remember that direct laryngoscopy still has to be used, so you're still looking for the landmarks as you go in, and everything else that you would normally do in an intubation without the bougie. You're still doing it that way. Remember, it's done gently and smoothly. And if you expect to have a difficult airway and a tough intubation, have your secondary device ready. If you come into a situation where you're looking to tube somebody and it just looks like they're going to be a difficult tube, have that backup device ready. But again, we like to see people use that skill that they have. Use the skill that you learned in school to intubate these patients and get that gold standard of airway control. For post-intubation, a couple things that I just want to mention because they're important. Remember to use the capnography. You got to use it. It's required by protocol, and it's just the best way for us to know that we're in the trachea and that your tube is still intact. And if you have not watched, again, the capnography video and on that module, I would suggest to please do that. It's actually a lot of good information in there, and you want to check that out. Remember to upload your cardiac monitor. And again, if you have capnography on, the uploading of the monitor is going to let you verify that your tube was in place. So if you ever come into question on a QI situation or a lawsuit, that recording of your monitor is going to have the end-tidal CO2 readings on it, and it's going to let you know for sure that you were in. It's going to keep you from getting in trouble or from being blamed for not having a tube in place. So keep those things in mind. Right? Last part of this, real quick, we're going to go over the ventilator, and we have 3 of these. There's one on the paramedic supervisor truck, there's one at Suburban Hospital, and then there's a third backup one floating around someplace. It's fairly easy. It's oxygen powered. It's got 3 dials, so you really can't make mistakes on this. I guess you can if you try hard, but it's fairly easy to use. So when you arrive for a transfer, the physician or respiratory therapist who's down there is going to give you settings for your tidal volume, which is here, and breaths per minute, which is there. If you have any questions about the operation or the settings, you need to contact a supervisor immediately, especially if you're going any distance with this. If you're uncomfortable with this piece of equipment, if you haven't used it before, if you have any questions, suck it up and ask the supervisor to come over and explain something to you, or talk to the staff at the hospital. You'd much rather have you ask the question before you go than feel embarrassed about asking a question and then have a problem with the vent later on, and then you're trying to bag somebody all the way to another destination. Not good patient care. So that goes with anything. If you don't get an opportunity to use this a lot and you're confused about it, just call somebody and ask. There's a bunch of parts in the box when you open it. All right, I'm going to go right in order here, starting with the valve. There is a valve right here that is attached to your D tank or your C cylinder, and this has the high pressure area on it. You need to use that if you're going to be using the D tank. So when you go into the hospital or into the facility to get the person out, you're initially going to use this. You have this oxygen hose. The oxygen hose connects to the regulator at the high pressure port. It screws on there, and then this part of the hose plugs into the supply tubing. The supply tubing is pre-connected to the control module down here, so this plugs into that, and this will also plug into the wall on the ambulance if you need to do that. And then you want to have a pre-connection here. So this patient valve, this is where the actual breaths are going to come out of. This is pre-connected to the other side of the control module. On there, you've got this rebreathing valve and hose. So this corrugated tubing goes on to the end of that. This is already in place, and then this connects to your ET tube, and your capnography would go right in between there like you would with a bag valve mask. So you'd have your tube, the capnography, and then this rebreathing valve and hose. There is a side port on this. We don't carry equipment to use this, but you can put a filter on there, or you can also put a PEEP valve on there if the patient requires PEEP for long term. Again, a long distance transfer that requires PEEP, we're either going to need to get one of these from the hospital, or they're going to have to get a ventilator that has a PEEP setting on it. Our ventilators do not have a PEEP setting. It's a valve, and we don't carry them. So this is how it's all going to go together. Once you get the patient out of the ambulance, you can do one of two things. It's going to connect the D cylinder, and you can stay on the D cylinder if you want to for a short transport, or you can go to the onboard oxygen system, which requires you to plug this into the wall, and that will help you to have a good connection to the oxygen on the wall. So either one of these will work. And at this point, we are done with the training video. So please watch this. This is a 14-minute video that is done by a MICU doctor. Talks about intubation. He gives some pretty good advice about difficult airways and getting the airway when you're having trouble. So I hope that everybody can take a chance to watch that. And it's a good airway video to check out. And it's only 14 minutes long. Again, thank you for watching, and if you have any questions about the Bougie, the auto vent, or any other airway stuff, please give me a call at extension 136, or you can get me at S. Helsman at tcaems.com. Have a good day.